Welcome to this deep dive, where we're tackling a condition that often presents as a subtle, persistent ache but can have profound impacts on wrist function: ulnar impaction syndrome, or UAS. For those of you navigating the complexities of wrist pain in your clinical practice, this exploration is specifically for you. Imagine a patient walks into your clinic with that nagging, persistent, ulnar-sided wrist pain, the kind that just won't quit, often worsening with simple daily tasks. Today, we're going to expertly navigate their journey, from pinpointing the exact cause ulnar impaction syndrome through to the latest evidence-based guidelines and management strategies. We'll cut through the information overload and deliver truly actionable insights into diagnosing and managing this often misunderstood condition. I'm joined by an expert in orthopedics who will help us unpack the critical details. Okay, let's unpack this.
It's a pleasure to be here. Ulnar impaction syndrome is certainly a significant and, at times, or perplexing area of focus in hand and wrist surgery. Our discussion today is underpinned by the recent Clinical Practice Guidelines for Ulnar Impaction Syndrome 2024, a collaborative effort from Washan Hospital's Hand Surgery Department and the Asian Pacific Wrist Association. These guidelines are truly a landmark, as they consolidate a vast array of evidence, aiming to standardize clinical practices and ultimately improve patient outcomes worldwide. They provide a scientific framework that we can all, I think, benefit from.
So let's begin with the fundamentals. For those of us who might need a refresher, what exactly is ulnar impaction syndrome at its core, and how does it typically manifest clinically in the patients we see?
Right. Ulnar impaction syndrome, often referred to as ulnar abutment, is fundamentally a degenerative condition. It's caused by the ulna, the longer of your two forearm bones, repeatedly impacting or, abutting against the carpal bones on the wrist's pinky finger side. This concept was first described by Milch way back in 1941, highlighting how prolonged, excessive load and impact during wrist movement can lead to pain and progressive damage.
So it's a wear and tear issue, essentially.
Precisely. Now, if left unaddressed, UIS can certainly lead to a cascade of quite severe issues. You might see thinning or even perforation of the triangular fibrocartilage complex, or TFCC.
That's that critical shock absorber and stabilizer on the ulnar side.
Exactly. We also observe bone marrow edema in the lunate bone, which is essentially bone bruising and inflammation, along with chondromalacia, which is a softening and damage to the articular cartilage. In more advanced stages, we can even find cystic changes within the wrist bones, or in the worst-case scenario, necrosis of the bone tissue, meaning bone death.
Which obviously has major functional consequences.
Absolutely. Ultimately, all of this significantly impairs wrist function, leading to reduced mobility and, crucially, diminished grip strength for our patients. One of the challenges for us as clinicians is that UIS is often overlooked or, perhaps even worse, misdiagnosed as purely a TFCC injury.
Right, leading to the wrong treatment path.
Exactly. This can lead to delayed or even inappropriate treatment. The typical symptoms are quite insidious, meaning they develop gradually and progress over time. Patients will often describe a chronic, progressive ulnar-sided wrist pain. Occasionally, they might notice some swelling or a reduction in their wrist motion or forearm rotation.
And certain movements make it worse.
Yes, almost always exacerbated by activities that involve forceful grip, pronation, like turning a doorknob downwards, and ulnar deviation, bending the wrist towards the pinky finger. What's particularly challenging in idiopathic cases, meaning those without a clear cause, is that patients usually don't report a specific acute traumatic event.
So no single aha moment of injury.
Often not. This really contributes to its insidious nature. It's vital for us to recognize that while wrist pain can have numerous causes, the specific presentation of UIS points to a distinct mechanical origin. The gradual onset and worsening with particular movements are classic hallmarks that should, raise our suspicion.
That truly highlights the insidious nature of UIS, making it a subtle but significant diagnostic challenge. What's even more fascinating, and frankly quite striking, is the biomechanical foundation of this condition. Could you elaborate on how variations in ulnar length, even the slightest ones, can contribute so profoundly to this impaction? It sounds like such a small detail with such a major consequence.
Absolutely. The biomechanics are utterly crucial to understanding why this syndrome develops and how seemingly minor anatomical differences can cascade into significant pathology. Consider a wrist that is ulnar neutral, meaning the ulnar and radius bones are roughly equivalent in length at the wrist joint. In this ideal scenario, the ulnocarpal joint bears approximately 18% of the total load across the wrist. The TFCC, which we mentioned earlier, is absolutely vital here. It acts as that critical shock absorber and load distributor, efficiently transferring this axial load from the carpus to the ulna.
Okay, 18% in a neutral wrist.
Yes. But here's where it gets really interesting and, frankly, Quite surprising. This load distribution is incredibly sensitive to relative ulnar length. Studies have robustly demonstrated that increasing the length of the ulna by just 2.5 millimeters, a mere 2.5 millimeters, less than the width of a small button, can drastically increase the ulnocarpal load to 42% of the total wrist load.
Wow, from 18% to 42%, that's more than double.
It is. Conversely, shortening the ulna by the same 2.5 millimeter can reduce that load to as little as 4%. That's a huge difference. This concept of small length changes leading to disproportionately large alterations in load is absolutely fundamental to the pathophysiology of UIS and directly informs our surgical strategies.
So even the slightest anatomical variation can snowball.
Precisely. When we talk about ulnar positive variance, we mean the ulna is intrinsically or acquiredly longer than the radius. This directly correlates with increased stress on the ulnocarpal side. When this variance exceeds that critical 2.5 millimeter mark, the stress on the ulnar side can increase from that baseline, say 20%, to as much as 40%.
And that's measurable stress.
Oh yes, this isn't just theoretical. It's a measurable increase in mechanical stress. This direct impaction and increased pressure accelerates TFCC wear and degeneration, leading to thinning and even perforation of its central portion over time. Then, the repetitive impact of the ulnar head on the lunate or trichotrum, which are the adjacent carpal bones, initiates a cascade of pathological changes. This includes chondromalacia, the cartilage damage, bone marrow edema visible on MRI scans, essentially a telltale sign of bone bruising, and reactive changes and cystic changes within the bones themselves.
And eventually even bone death, the necrosis.
In severe, prolonged cases, this can unfortunately progress to a vascular necrosis of these carpal bones, meaning the bone tissue actually dies due to lack of blood supply, fundamentally impairing wrist function.
It's quite a cascade.
It is. It's also crucial to consider the dynamic component of this condition. We've found that wrist ulnar pressure increases significantly during activities that involve forceful pronation, fist clenching, and ulnar deviation. A retrospective case study provided a crucial insight here. It revealed an average ulnar positive variance of 2 millimeter during pronation, even in cases where there was no static ulnar variance evident on a standard X-ray.
Ah, so it might look normal at rest, but under load.
Exactly. This dynamic aspect is key because it explains why UIS can occur even in wrists that appear ulnar neutral or even slightly negative in static, non-loaded X-ray views. It's the repeated microtrauma from these dynamic loads, often occurring during everyday or sports activities, that truly drives the degenerative process, even when static imaging looks perfectly normal.
So we're not just looking at a static picture, we're considering a dynamic, active process of wear and tear. So, if the subtle and dynamic nature of this condition means it isn't always screaming at us from a static image, then a truly definitive diagnosis clearly requires a multifaceted approach. What does that comprehensive assessment look like beyond just the patient's reported symptoms? How do we piece together the puzzle?
You're absolutely right. Diagnosis involves a comprehensive and multifaceted assessment, bringing together the patient's detailed medical history, a thorough physical examination, and crucially, objective imaging findings. It's imperative to understand that without supportive X-ray and MRI results, a diagnosis of UIS should not be considered in isolation.
Clinical suspicion isn't enough on its own.
Not really. Relying solely on clinical symptoms can easily lead to misdiagnosis because, as you know, many conditions can cause ulnar-sided wrist pain. We're talking about potentially 20 or more differential diagnoses. From a clinical standpoint, as we discussed, patients often present with prolonged ulnar-sided wrist pain, typically with a gradual, insidious onset, often exacerbated after maintaining specific wrist positions or engaging in forceful activities. A key diagnostic physical examination maneuver we use is the ulnocarpal stress test.
The Nakamura test.
Yes, as described by Nakamura and colleagues. This involves placing the wrist in full ulnar deviation, then applying axial pressure through the wrist, and finally passively rotating the forearm through pronation to supination. A positive test, which reproduces the patient's typical ulnar-sided pain, is highly suggestive of UIS.
Suggestive, but not definitive.
Correct. It's important to remember that it is not pathognomonic, meaning it's not a definitive smoking gun sign that only indicates UIS. A positive result can also indicate other conditions, such as a TFCC injury without impaction, scapholunate ligament damage, or isolated arthritis. So it's a strong indicator, but it needs to be interpreted within the broader clinical context and always alongside imaging.
What else might you find on examination?
Other findings might include very specific tenderness to palpation on the dorsal aspect of the ulnar head itself, or just distal to the ulnar head and ulnarly, just volar to the styloid process. If there's concurrent distal radial joint, or DRUJ, Instability, meaning the joint connecting the two forearm bones at the wrist, is loose. A positive DRUJ allotment test may be elicited, where we're feeling for abnormal movement or clunking.
Testing for that instability.
Yes. The lunotriquetral allotment test, similarly, where we feel for abnormal looseness between those two small carpal bones, can sometimes clue us into midcarpal instability, which can sometimes be a secondary issue. Given that there are approximately 20 different conditions known to cause ulnar-sided wrist pain, diagnosing based solely on history and physical examination is truly insufficient for a definitive diagnosis of UI. Imaging is paramount for confirmation.
It's clear that imaging plays a pivotal, indeed indispensable role in confirming this diagnosis and really differentiating it from other conditions. What are the primary imaging modalities clinicians should be relying on, and what specific findings should we be looking for to solidify a UIS diagnosis?
Precisely. X-rays and MRI are recommended as the primary imaging modalities for confirming UIS. For X-rays, a neutral rotation posterior anterior, or PA, view of the wrist is absolutely essential. This view allows us to accurately determine the static ulnar variance, which is the relative length of the ulna to the radius. This is our baseline.
The standard starting point.
Yes. But to capture the full picture, especially for dynamic impaction, a pronated grip PA radiograph is also crucial. This view can demonstrate that dynamic positive ulnar variance that might not be visible in a static neutral position. It's designed to capture the very loads that often cause the syndrome by having the patient grip something firmly while pronating their forearm.
Trying to reproduce the problematic loading.
Exactly. Typical X-ray findings indicative of UIS primarily include, of course, ulnar positive variance. In more severe or chronic cases, you might observe classic signs of degeneration. Cystic changes on the ulnar side of the lunate or triquetrum.
Those little low-density shadows.
That's right, appearing as circular low-density shadows on the radiograph, essentially tiny pockets or voids forming within the bone, a clear sign of chronic mechanical stress. Subchondral sclerosis, which is increased density of bone just beneath the cartilage, appearing brighter on the X-ray, or other cystic changes, may also be present at the dome of the ulna, or the ulnar corner of the lunate or the triquetrum. These are the telltale signs of bone reacting to chronic, repetitive mechanical stress.
Okay, so X-rays show the bone structure and chronic changes. What about MRI?
While X-rays provide a structural overview, MRI findings truly take precedence in terms of soft tissue and early bone marrow changes. A T2-weighted coronal MRI should demonstrate increased signal intensity in the lunate, triquetrum, or ulnar head. This increased signal is indicative of bone edema.
That bone bruising again.
Exactly, which represents the early inflammatory and reactive changes within the bone due to the ongoing impaction. For example, if you were to look at a typical guideline image like Figure 1A, you'd clearly see this bright signal in the lunate. Additionally, MRI is superior for evaluating the TFCC. Thinning or frank perforation of the central portion of the TFCC on T2-weighted images is a significant finding.
Showing the direct damage to the TFCC itself.
Yes, this thinning or perforation is a direct result of the repetitive mechanical load and impaction on this vital fibrocartilaginous structure. Again, in guidelines, Figure 1A perfectly shows this thinning and perforation of the central TFCC. For cases without apparent static ulnar positive variance on initial X-rays, those forearm rotation views we discussed become specifically recommended on MRI to confirm that dynamic ulnar impaction.
So MRI can pick up both the bone reaction and the soft tissue damage, and even help confirm dynamic issues.
It's all about putting these pieces together. The patient's story, our examination, and these precise imaging clues.
So once we've successfully navigated that diagnostic pathway and definitively diagnosed ulnar impaction syndrome, what's the initial recommended approach for managing it? Is conservative treatment always the first line? And if so, what does that typically involve for our patients?
Yes, conservative treatment is strongly recommended as the primary therapeutic approach for UAS, particularly during the initial diagnostic phase, before considering more invasive options. The overarching goal here is to alleviate symptoms, reduce inflammation, and crucially, offload the affected ulnocarpal joint to allow for healing and symptom reduction.
Makes sense. Give it a chance to settle down.
Exactly. The typical conservative regimen outlined in the guidelines involves continuous splint fixation for an initial 4-week period. This means the patient wears a short arm splint continuously. Following this, they'll transition to intermittent wear of the splint for another 2 weeks.
So 6 weeks of splinting in total, just tapering the use.
That's right. This extended immobilization aims to provide substantial rest and significantly reduce the mechanical stress on the wrist. Once the splint is completely removed, a structured 6-week rehabilitation program is then initiated. This program focuses on carefully restoring wrist strength, improving range of motion, and gradually returning the patient to functional activities.
And pain relief during that time.
For pain relief during this period, oral nonsteroidal anti-inflammatory drugs, or NAS, are commonly administered. These medications help to reduce both pain and inflammation. In those more severe cases where NSAIDs alone are simply insufficient to control the pain, localized pain point blockade on the ulnar side of the wrist may be considered.
A targeted injection.
Yes, injecting an anesthetic or a corticosteroid directly into the area of maximal tenderness to provide more immediate and targeted relief. Crucially, patient education is paramount during this phase. Patients are strongly advised to significantly minimize activities that exacerbate the ulnar load.
Like avoiding that forceful gripping and twisting.
Precisely. This includes avoiding or modifying activities that involve forceful ulnar deviation and pronation of the wrist, which, as we discussed earlier, directly increase the ulnocarpal load and can perpetuate the problem.
And how successful is this conservative approach generally?
Well, looking at the evidence, studies indicate a 51.7% overall improvement rate in pain scores with long-term splint immobilization, which is quite significant for a non-operative approach. More specifically, after the 6 weeks of splinting and the subsequent 6 weeks of structured rehabilitation, a solid 59% of patients achieved a numeric rating scale score of less than 5.
Which you'd consider a successful outcome.
Generally, yes. This is typically considered a successful outcome for conservative treatment, allowing patients to manage their symptoms effectively without surgery. However, it's equally important for us to acknowledge that 41% of patients still had a score of 5 or higher after this comprehensive conservative trial.
So not quite half, but a significant portion don't get enough relief.
That's right. These patients are then considered conservative treatment failures, at which point surgical intervention must be seriously considered as the next, more definitive step. So while conservative measures are the first line, they are not universally successful, and it's important to set realistic expectations for our patients.
That's a clear benchmark for when conservative treatment isn't sufficient. So if those measures don't yield the desired outcome, or if symptoms are particularly severe, surgical intervention clearly becomes necessary. What are the clear indications, then, for us to consider early surgical intervention in patients with ulnar impaction syndrome?
If conservative management doesn't achieve adequate pain relief or functional improvement, surgical intervention is indeed the logical next step. There are clear evidence-based indications for considering early surgical intervention in our UIS patients. It is strongly recommended for individuals whose ulnar-sided wrist pain persists for a significant period, specifically for 6 months or longer, despite having undergone a full, diligent course of conservative treatment without sufficient relief.
6 months is quite a long time to be in pain despite trying conservative options.
It is. This isn't just about pain scores. It also applies to patients who exhibit severe clinical symptoms, such as a significantly decreased wrist joint range of motion, which impacts their ability to perform daily tasks, or markedly weakened grip strength, affecting their work or hobbies. Case series studies consistently show that conservative treatment is often less effective in these persistent or severe cases, where the underlying mechanical problem is likely more advanced and requires direct correction.
The mechanics just aren't improving.
Exactly. For example, in one notable case series of patients undergoing ulnar shortening osteotomy for UAS, all had prolonged pain, significantly reduced range of motion, and severely weakened grip strength despite 6 months of conservative treatment, and all subsequently achieved very favorable surgical outcomes. This demonstrates the surgical imperative in these chronic, severe cases.
Okay, so chronic pain and functional deficits are key indicators. What else?
Furthermore, early surgical intervention is also highly recommended for UIS patients who present with concurrent distal radiolateral joint, or DRUJ, instability. This is a critical comorbidity.
Ah, the instability factor again.
Yes. When the DRUJ is unstable, it significantly compounds the patient's pain and functional limitations. Surgery has been confirmed as a reliable method to improve UIS, specifically when it's complicated by DRUJ instability. Post-operatively, these patients consistently demonstrate significant improvements in pain scores, as well as functional scores like the quick disabilities of the arm, shoulder, and hand, or QUICK-DASH, and patient-rated wrist evaluation scores.
So surgery can tackle both the impaction and the instability.
It indicates that addressing the instability surgically, often by correcting the ulnar length, resolves a significant component of their overall wrist dysfunction and pain, leading to a much better quality of life. So, for chronic pain, significant functional deficits, or coexisting DRUJ instability, surgery should be firmly on our minds.
Right, so we've established the when. Now, let's delve into the how. When we talk about surgical solutions, ulnar shortening osteotomy, or USO, is often considered the gold standard. Could you outline its principles, its distinct advantages, and then walk us through some of the crucial considerations, including the choice of fixation, that we need to be mindful of in practice?
Ulnar shortening osteotomy, or USO, truly is a precise and widely recommended standard treatment for UAS. Its fundamental principle involves surgically removing a specific length of the ulna, essentially, a measured segment typically at the distal one-third of the ulnar shaft. The primary aim is to eliminate any ulnar-positive variance, thereby directly reducing the repetitive grinding impact between the ulna and the adjacent carpal bones, particularly the lunate and triquetrum.
Addressing the root mechanical cause.
Precisely. By shortening the ulna, it directly alleviates the excessive loading on the ulnocarpal joint. Importantly, beyond just offloading, USO also significantly enhances DRUJ stability, which is often compromised in these conditions, by effectively retensioning the surrounding ligamentous structures.
So it helps with stability, too. That's a key advantage.
It is. The key advantages of USO are noteworthy and make it a preferred choice for many patients. Firstly, and crucially, it's an extra-articular procedure. This means it doesn't require opening the joint capsule of the wrist.
Which minimizes damage to the joint itself.
Exactly. This is significant because it helps to avoid direct damage to the articular cartilage of the DRUJ and also preserves the integrity of the triangular fibrocartilage complex, or TFCC structure, which is vital for wrist function. Secondly, clinical outcomes are consistently very encouraging. Patients typically show significant improvement in wrist joint flexion extension, ulnar radial deviation, and pronation-supination range of motion, while also experiencing a dramatic reduction in their pain scores.
So good functional results and pain relief.
Yes, the procedure's ability to precisely shorten the ulna directly contributes to DRUJ stability by increasing tension in the joint capsule and surrounding ligaments, which is a key biomechanical benefit we're looking for.
Are there any specific cases where you need to be cautious with USO?
Yes, there are crucial considerations. One subtle but important anatomical factor is the morphology of the DRUJ sigmoid notch. Caution is specifically advised in cases of Talat C-type DRUJ, which describes a reverse oblique sigmoid notch. In such anatomies post-USO, the ulnar head may collide with the distal radial sigmoid notch.
Causing a new problem.
Potentially, yes. It could increase contact pressure and lead to secondary DRUJ arthritis over time. This is why careful preoperative imaging assessment of this specific morphology is so vital.
What about the specifics of the cut itself or the fixation? Does that make a difference?
Regarding the choice of osteotomy type, whether to perform a transverse or oblique cut meta-analyses, comparing these approaches, or indeed comparing freehand techniques versus those using a precise osteotomy guide, have shown no statistically significant difference in non-union rates.
So surgeons have some flexibility there.
It provides surgeons with welcome flexibility, allowing them to choose the osteotomy type and technique based on patient-specific conditions and their personal preference or surgical expertise, rather than being dictated by a perceived superior union rate. For internal fixation, both locking and non-locking plates are recommended and commonly used for USO surgery.
Locking versus non-locking plates? Any major difference?
Well, while some studies hint at slightly longer bone healing durations with non-locking plates, current evidence does not demonstrate a significant biomechanical advantage for locking plates in terms of overall strength or stability for this particular procedure. Therefore, the choice here can also be based on surgeon preference and experience.
Okay. What about where the plate goes?
That's important. A critical recommendation for plate placement is to position fixation plates on the volar side of the ulna rather than the dorsal side. Dorsal plates are consistently associated with significantly higher rates of post-operative irritation and subsequent removal, sometimes as high as 45% to 65% in reported series.
That's a huge difference compared to volar plates.
It is. In contrast, volar plates see removal rates closer to 25%. This is a practical but impactful consideration for patient comfort and reducing the need for secondary hardware removal procedures. It truly makes a difference to the patient's long-term experience.
That's incredibly detailed regarding USO. But beyond what many consider the gold standard, what other surgical options are available to us, particularly the wafer procedure? And perhaps more importantly, when might that be a more appropriate or even preferred choice over USO, considering its own unique profile of advantages and disadvantages?
The wafer procedure, or arthroscopic wafer procedure, AWP, offers a distinct alternative to USO. particularly for specific patient profiles. This technique, first proposed in 1992, involves resecting a small, precise amount, typically 2 to 4 millimeters from the distal end of the ulnar head. The goal, similar to USO, is to achieve ulnocarpal decompression by effectively creating more space at the ulnocarpal joint. With advancements in arthroscopic techniques, it can now be performed minimally invasively.
Which patients often prefer.
Indeed, it's often appealing to both surgeons and patients due to reduced scarring and potentially faster initial recovery. This procedure is specifically recommended for UIS patients with ulnar positive variants of less than 2 millimeters.
So only for small amounts of positive variance.
Correct. It's crucial to note a strict contraindication. If the anticipated osteotomy length needed exceeds 3 millimeters, the wafer or AWP is generally not recommended. This is a critical limitation of the procedure, as going beyond this can lead to new problems.
What are the main upsides compared to USO then?
The key advantage of the wafer procedure lies in preventing several issues common to USO. It completely eliminates the risk of osteotomy non-union, as no osteotomy is performed. It also inherently reduces internal fixation irritation and negates the need for subsequent hardware removal simply because no internal fixation is typically used.
No cut, no plate, fewer of those complications.
Exactly. This translates to lower potential complications and reoperation rates compared to USO in appropriately selected cases. Furthermore, it is particularly advantageous for UIS patients who present with that specific TOLAT C-type DRUJ reverse oblique sigmoid morphology, where, as we discussed, USO might risk increased contact pressure and secondary arthritis.
Okay, but what about the downsides? There must be some trade-offs.
Oh, certainly. It does come with notable disadvantages, and it's important to be clear about these trade-offs. Firstly, it creates an irreversible injury to the articular cartilage of the ulnar pole, as bone and cartilage are removed directly from the joint surface. This is a permanent alteration.
You're essentially removing part of the joint surface.
Yes. Secondly, it is technically more demanding than a standard USO, requiring precise arthroscopic skills and specialized equipment. As mentioned, its shortening capability is limited, typically to just 2 to 3 millimeter, making it unsuitable for more significant ulnar-positive variants. Additionally, the recovery time to achieve satisfactory pain relief can be prolonged, often taking 3 to 6 months.
Longer recovery than USO, potentially.
Sometimes, yes, for pain relief specifically. A significant functional drawback is that it does not retension the surrounding ligaments. This means it won't correct pre-existing DRUJ or lunotriquetral instabilities, nor will it resolve stylocarpal impaction if that is present.
So it doesn't help with instability like USO does.
Correct. Cadaver studies provide a clear warning. Excessive ulnar side pressure increases significantly with more than 3 millimeters of ulnar head grinding, with 4 millimeters of removal actually doubling the pressure compared to the original load.
Which underlines why you stick to that 2-3 millimeter limit.
Absolutely. This underscores why the shortening limit is so crucial to avoid secondary problems and why patient selection is paramount. So while it avoids some complications of USO, it introduces its own set of trade-offs and is indicated for a narrower range of variants.
That's a very clear distinction between USO and the wafer procedure. It sounds like each has its niche. What about distal metaphyseal ulnar shortening osteotomy, or DMUSO? When should this technique be considered, and what are its particular advantages that might make it a compelling choice in certain scenarios?
Distal metaphyseal ulnar shortening osteotomy, or DMUSO, a technique detailed by Slade in 2007, is another important surgical option that sits somewhat between the traditional diaphyseal USO and the wafer procedure. It's recommended for anticipated osteotomy lengths of less than 5 millimeters in UIS, offering a slightly greater range of shortening than the wafer, but potentially less than some of the more extensive USO applications.
So for moderate shortening needs, up to 5 millimeter.
That's a good way to think of it. DMUSO offers several distinct advantages that make it attractive. Due to its distal osteotomy location, specifically in the metaphysis, which is the wider part of the bone near the joint, known for its richer blood supply compared to the diaphysis, or shaft.
Better blood supply means better healing.
Generally, yes. It tends to have a shorter healing time and a lower non-union rate compared to traditional USO. This enhanced healing potential is a significant benefit for patients, often leading to a quicker recovery. Furthermore, because it's performed more distally, closer to the wrist, it reduces the separation and traction effects on the interosseous membrane, that tough fibrous sheet between the radius and ulna.
Potentially less disruption nearby.
Yes, which can potentially lead to less postoperative discomfort and faster rehabilitation. Studies have even shown it can be more effective than traditional USO in relieving pain and improving quick DASH scores, which measure hand and arm function, suggesting superior functional outcomes in some patient cohorts.
And fixation, is it different from USO?
For fixation in DMUSO, buried head compression screws are often preferred over ulnar distal plates.
Screws instead of plates, why is that?
The primary reason for this preference is that these screws lead to fewer postoperative complications, particularly less internal fixation irritation, which, as we discussed, is a common complaint with plates. The technique also allows for flexible fixation options. Surgeons can choose either retrograde fixation, where the screws are inserted starting from the ulnar head cartilage surface and extending towards the distal end, or antegrade fixation from the ulnar shaft towards the ulnar head.
Which works best?
Well, cadaver studies providing crucial biomechanical insights have shown that using two antegrade screws provides the highest resistance to rotation stability without causing damage to the joint surface.
So DMUSO offers good healing, potentially better outcomes for moderate shortening, and less hardware irritation.
It makes DMUSO a compelling option for specific shortening needs, balancing effective decompression with improved healing characteristics and reduced hardware issues, making for a smoother patient journey post-op.
That's a comprehensive overview of the primary surgical shortening options. Now, let's turn our attention to what often feels like the intricate heart of this condition for many of us in practice: the frequent co-occurrence of UIS with TFCC injuries. What is the precise role of TFCC repair in treating UIS, and how should we as clinicians truly approach these combined, often confusing conditions?
This is indeed a critical area, and it's where much of the diagnostic and treatment nuance truly lies. While TFCC injuries frequently co-occur with UIS, current clinical studies provide a very clear and important recommendation. Performing TFCC debridement and repair alone is not recommended as a sole treatment for confirmed UIS.
So just fixing the TFCC isn't enough if there's underlying impaction.
That's the key takeaway. The evidence here is quite strong and should guide our practice. Approximately 25% to 30% of UIS patients who initially underwent only TFCC debridement and repair subsequently required a USO within a relatively short period postoperatively, around 3.6 months on average. Furthermore, repairing the TFCC alone, while it might show some short-term improvement in ulnar-positive variants, tends to worsen again over time, averaging around 26.8 weeks, and is accompanied by persistent pain.
So the problem comes back because the underlying mechanics weren't addressed.
Precisely. This tells us that if the underlying mechanical impaction from the ulnar length discrepancy isn't addressed, simply fixing the TFCC won't provide lasting relief for UIS.
What about doing the shortening without repairing the TFCC?
Conversely, ulnar shortening surgery, such as a USO, has been shown to effectively improve clinical symptoms in UIS patients, even those with TFCC central perforation or radial edge tears that cannot be directly sutured. In fact, a surprising finding in recent studies is that performing USO alone can yield clinical results comparable to USO combined with TFCC debridement, with no significant differences observed in postoperative hand function scores, grip strength, or pain relief.
Really? Even with a known TFCC tear?
Yes. Even in patients with UIS and minor TFCC injuries alongside DRUJ instability, most achieve significant improvement in DRUJ stability through USO alone, as the shortening increases tension in the ligamentous structures that stabilize the joint.
It's almost as if correcting the bony alignment takes the strain off the soft tissues, allowing them to heal or function better.
That's a good way to put it. However, and this is a crucial caveat, for cases where DRUJ instability persists after ulnar shortening, it is then recommended to consider concomitant TFCC foveal repair.
So address the bone first, and if instability remains, then repair the TFCC.
Exactly. This combined approach is often necessary to truly restore optimal DRUJ stability, suggesting a hierarchical approach where the bone length is addressed first, and then specific, persistent soft tissue instabilities are targeted if the primary bony correction isn't sufficient for full stability.
This leads us to a fascinating and complex question that you, as clinicians, will face daily. How do we differentiate between primary UIS and secondary ulnar-positive variants caused by DRUJ instability? The distinction seems vital.
It is absolutely vital for accurate treatment and avoiding unnecessary procedures. Primary UIS typically presents with increased signal intensity, thinning, or central TFCC perforation on MRI, directly reflecting the chronic impaction. If the ulnar-positive variance, however, is primarily due to DRUJ instability, there's usually a clear history of trauma preceding the symptoms, like a fall onto an outstretched hand.
A different mechanism of injury.
Yes. On MRI, you might not see obvious signal changes in the ulnar positive variance itself, and TFCC injuries are more concentrated in the ulnar-sided fovea, the deep attachment point of the TFCC, rather than central perforations. A case series of 140 patients revealed that TFCC deep support injuries could increase ulnar positive variance by an average of 0.56 millimeters. Crucially, after restoring DRUJ stability through repair of these deep injuries, the ulnar positive variance was reduced to 0 millimeter.
Wow, so fixing the instability corrected the apparent positive variance.
It's a powerful demonstration of the causal link in those cases. Our current understanding suggests that instability initially caused by a TFCC injury, particularly in younger, more active patients, can lead to dynamic ulnar impaction syndrome. Then, with the ongoing aging process and repeated microtrauma, compensatory degenerative changes occur.
So the sequence matters, TFCC injury first, leading to impaction over time.
That's the thinking. This means that younger patients with UIS often have underlying TFCC-related problems that may indeed require both TFCC repair and USO to achieve stability and pain relief. In contrast, older patients might only require USO if the DRUJ instability is no longer a significant factor, perhaps due to age-related stiffening or adaptation.
So age and activity level play a big role in the treatment decision.
Absolutely. Therefore, accurately identifying whether both lesions, the impaction, and the TFCC instability are combined, and understanding their chronological relationship and the patient's age and activity level is truly key to achieving a successful outcome. It's a nuanced dance between bone and soft tissue.
That's a profound and incredibly practical insight into the progression and nuanced interplay of UIS and TFCC issues. It certainly raises crucial questions about how we approach these combined conditions, doesn't it? But what happens when, despite our best efforts with primary procedures, UIS progresses to severe DRUJ arthritis, fundamentally altering the joint? At that point, what are the salvage procedures available, and how do we decide which one is best for our patient?
When UAS has progressed to severe DRUJ arthritis, and primary procedures like USO or the wafer procedure have unfortunately failed to alleviate symptoms or are no longer appropriate given the extent of joint destruction, salvage procedures become necessary. At this stage, the goal shifts from preserving the native joint to dramatically improving forearm rotation and alleviating chronic wrist pain. The two most widely used salvage procedures in this scenario are the Soveka-Punji, or SK surgery, and the Doric surgery.
Okay, SK and Darac. How do they differ?
Doric surgery is essentially an excision arthroplasty involving the complete removal of the ulnar head. The intention is to eliminate the source of pain from the arthritic joint and allow for improved rotation.
Just remove the painful bit. Seems straightforward.
Well, while it is a relatively straightforward procedure to perform and can offer quick pain relief, its main drawback is the potential for significant complications due to the complete loss of the ulnar head's supportive role. These can include radiocarpal joint instability, an undesirable ulnar deviation of the wrist, often called a caput ulni deformity, and impingement between the remaining ulna stump and the radial aspect.
So removing it can cause other stability problems.
It can. It's generally considered more suitable for elderly patients, especially those with lower functional demands for their wrist, where simpler pain relief is the primary goal, and the biomechanical consequences are less impactful on their daily life.
And the Soveka-Punji.
SK surgery, on the other hand, is a more complex reconstructive procedure. It involves a partial osteotomy of the distal ulna combined with a DRUJ fusion, meaning the distal ulna and radius are surgically joined. But crucially, it preserves the ulnar head and the TFCC, creating a pseudoarthrosis, or a false joint, just proximal to the fusion.
So you fuse the joint but create a new motion segment nearby.
Exactly. By retaining the ulnar head and TFCC, it offers better rotational and axial stability compared to Dirac, as these structures still contribute to the overall wrist mechanics.
That sounds more complex. Any drawbacks?
Its main drawbacks include a higher overall complication rate, such as delayed healing or non-union of the DRUJ fusion, and the potential for painful instability of the ulnar stump if the shortening component exceeds 5 mm. Despite these risks, SK is typically more suitable for younger, male patients who inherently have higher wrist joint function requirements and whose lifestyle demands greater stability and strength.
Better function, but higher risk.
In essence, yes. Studies have shown a notably higher return-to-work rate for SK surgery at 86%, compared to 63% for Dirac, underscoring its functional benefits for active individuals. So the choice between these two significant salvage procedures depends heavily on patient age, their functional demands, and the specific radiographic findings of the arthritic joint and surrounding structures. It's a very patient-specific decision.
That's a thorough overview of the surgical options, from primary procedures to salvage interventions. Finally, let's consider the crucial post-operative phase, which is equally vital for a successful outcome. What are the recommended immobilization and rehabilitation strategies following these different surgical interventions for UIS, and how do they vary?
Postoperative protocols are indeed crucial for successful outcomes and vary significantly based on the specific surgical procedure performed. It's certainly not a one-size-fits-all approach, and tailoring it to the patient and procedure is key.
Right, so let's start with the USO, the ulnar shortening osteotomy.
For ulnar shortening osteotomy, USO, a short arm orthosis is typically sufficient for immobilization. This is usually maintained for 4 weeks to allow for initial bone healing at the osteotomy site, given that we've performed a bony cut. Rehabilitation exercises, focusing on regaining range of motion and strength, generally commence after this 4th week.
4 weeks immobilized, then start rehab. Is there any debate about starting earlier?
Well, while some early reports advocated for earlier functional exercises, a retrospective cohort study provided a cautionary note, reporting a 10% non-union rate with immediate wrist movement after USO. Therefore, prudence is advised, and a structured, delayed approach to vigorous wrist movement is generally preferred to protect the healing bone.
Better safe than sorry with the bone healing.
Quite. However, it's important to encourage early active movement for all non-fixed joints, such as the fingers and elbow, to reduce swelling and promote overall healing without disturbing the osteotomy site itself.
Okay, what about after a wafer procedure, shorter immobilization?
Yes, following a wafer procedure, the immobilization period is typically much shorter due to the absence of an osteotomy and the nature of the procedure. A 2-week immobilization with a short arm splint is generally recommended. During these first 2 weeks postoperatively, exercises that involve making a fist or engaging in axial stress training of the wrist are generally not advised, as these can put undue pressure on the healing tissues and the resected bone surface.
And rehab starts sooner.
Rehabilitation exercises typically begin more aggressively in the 3rd week, focusing on regaining motion carefully. This approach has shown high improvement rates in pain outcomes, leveraging the less invasive nature of the procedure and often allowing patients to progress more quickly in the very early stages.
And finally, the DMUSO, the distal metaphyseal shortening.
For distal metaphyseal ulnar shortening osteotomy, DMUSO, the postoperative protocol benefits significantly from the specific anatomical site of the osteotomy. Due to the richer blood supply in the metaphysis compared to the diaphysis, there's a lower probability of non-union. This inherent biological advantage allows for a shorter fixation time.
So quicker healing allows for quicker mobilization.
Essentially, yes. We typically recommend short arm plaster fixation for just 7 to 10 days, after which it's followed by a switch to a wrist brace for continued protection as the bone continues to consolidate. Crucially, rehabilitation can start as early as the 10th postoperative day, allowing for earlier intervention in wrist joint rehabilitation and potentially a faster return to full function and activity compared to traditional USO.
So quite a range of rehab protocols depending on the exact surgery.
It highlights how this choice of surgical technique directly impacts not just the surgical outcome, but also the entire postoperative recovery timeline
Yeah.
and our patients' expectations.
What a comprehensive exploration of ulnar impaction syndrome. It's clear that while UIS is prevalent, it often goes undiagnosed, or its complex relationship with TFCC injuries is overlooked. This discussion underscores the necessity of a multifaceted approach, combining meticulous clinical assessment, advanced imaging, and a truly tailored surgical or conservative strategy. The guidelines we've discussed today really provide a scientific compass, helping clinicians navigate this intricate wrist pathology with greater confidence. So what does all of this mean for you in practice? The ability to accurately diagnose and distinguish between static and dynamic impaction, to understand the nuanced, often causal role of TFCC instability, and then to select the most appropriate surgical or conservative pathway, crucially considering factors like the morphology of the DRUJ, the patient's age, and their functional demands is truly the key to unlocking better outcomes for those patients presenting with ulnar-sided wrist pain. It's about moving from a general diagnosis to a truly precise patient-specific treatment plan. One lingering question that often arises is, how can we better identify dynamic impaction earlier, perhaps even in asymptomatic patients who have subtle positive variants, to potentially prevent the full progression of the syndrome? Something to ponder as you reflect on today's conversation. If you found this deep dive valuable, please consider giving us a rating and sharing it with a colleague who might benefit. We hope this session serves as a valuable reference in your clinical practice, illuminating the complexities of UIS and empowering you with evidence-based strategies. Thank you for joining us on Deep Dive Ortho. We'll be back soon with another exploration into the frontiers of orthopedic knowledge.